Hi again, everyone. My name is Courtney Bunner. Like I said, I'm the newest infectious diseases pharmacist here at Ruby Hospital. I just started about 2 months ago, so I'm excited to be back. Today, the topic is skin and soft tissue infections. And you can go to the next slide.
Did it advance?
No.
Hold on just a second. Sometimes I have troubles with this. Let me do it this way. Just give 1 second. Okay.
You can just go to the second slide. All right, so the focus of the next 5 to 10 minutes is just going to be on the role of sulfamethoxazole trimethoprim, which I'll refer to as Bactrim, and skin and soft tissue infections or SSTIs. You can go to the next slide. So the most common pathogens that we think about with skin and soft tissue infections are group A streptococcus and staphylococcus aureus. The next slide. And with the most recent IDSA SSTI guidelines, which really aren't that recent because the last time they were updated was July of 2014, which was about 10 years ago, which is crazy. But these are the oral treatment options for either group A strep or Staph aureus. And you can see that they're pretty similar with the exception of doxy, which doesn't really have great strep coverage, but can be used in Staph aureus at times when it shows susceptibility. You can see on here, I did put a question mark beside clindamycin. It's not my favorite choice for an empiric option for SSTIs. If you go to the next slide, we can see the susceptibility rates for Staph aureus for MRSA and MSSA. Looking at clindamycin, the susceptibility rates are pretty low, so trying to stray away from that, especially as an empiric option whenever we're thinking about Staph aureus. And just honing in on other options like tetracyclines, the susceptibility rates are kind of a little bit higher than clindamycin, still over 80%. And then Bactrim, we can see has some higher susceptibility rates as well. And then linezolid is 100% susceptible to either MRSA or MSSA. So these are all good options for SSTI. Next slide. So when we're thinking about treating an SSTI and we're thinking about both group A streptococcus and Staph aureus, according to the guidelines, the options that we have are really linezolid or an oral cephalosporin like cephalexin, and we're thinking about MSSA in particular. You can go to the next slide. But if we have a patient that is unable to take linezolid for whatever reason, being that they might have significant drug interactions with multiple serotonergic agents on board, that rules out that option, or they might have a severe beta-lactam allergy, then there's really not another good option besides clindamycin, but sometimes we try to avoid that as well. But Bactrim has been a proposed option to cover both group A strep and Staph aureus. But according to the most recent guidelines, if we're covering for both, and we think that group A strep is a pathogen at play here, then it's recommended sometimes to add on another agent for streptococcus. If you go to the next slide. There has been some hesitancy in the past with Bactrim for group A strep coverage, and we'll kind of go through the history of that. So starting in the 1930s, group A strep infections were treated with sulfur antibiotics, and then they started to use sulfadiazine in mass prophylaxis to prevent group A strep tonsillitis and acute rheumatic fevers. So we would expect maybe some resistance to develop there. But then they started to come out with some antimicrobial susceptibility testing of group A strep isolates to sulfur antibiotics using some broth dilution methods. And that did demonstrate some resistance to some strains, which led to the paucity of using Bactrim in group A strep infections after that. You can go to the next slide. In 1945, there was a study that discovered a substance called thymidine. And this really showed that thymidine levels in culture media was directly related to bacterium resistance. And the thymidine was used by the bacteria to maintain folate metabolism, which basically just interferes with the way that bacterium works and kills the bacteria and essentially let more bacteria live than be killed by the bacterium. So bacterium appeared resistant to group A strep isolates whenever thymidine was present at certain levels in this culture media, which would show up as resistant in antimicrobial susceptibility testing studies. And in 2006, the CLSI actually kind of made a rule that thymidine levels had to be limited in culture media to kind of prevent the false resistance showing up in group A strep susceptibility testing. If you go to the next slide. So looking at some studies after this limitation of thymidine in 2012, there was a study by Bowen that showed in vitro study testing susceptibility of two sets of strep pyogenes or group A strep isolates to bacterium on different types of media. It did show that 99% and 100% in two different studies of the isolates were susceptible to bacterium on all types of media. And we can see the mean MIC of was 0.05 or less or 0.16 or less in both studies. Of note, the CLSI doesn't have defined breakpoints for bacterium to strep pyogenes or group A strep right now, but the UCAS does have defined breakpoints, which I've provided on the slide there. You can go to the next slide. And there was a subsequent study by the same author in 2017 that did a systematic literature search to determine the clinical efficacy of Bactrim for SSTIs, and then update some previous reviews of in vitro susceptibility to group A strep to Bactrim. It did include 15 studies, and 10 of those were randomized control trials, and ultimately the findings supported Bactrim for use in treatment of impetigo and purulent cellulitis. Of note, whenever we're thinking of purulence, typically that means that Staph aureus is involved. And whenever it was used for purulent cellulitis, they deemed that it was appropriate to not use an additional beta-lactam agent, and also it was appropriate for abscess and wound infections. But for non-purulent cellulitis, so whenever we're thinking of group A strep alone, then beta-lactams remain the treatment choice. You can go to the next slide. Some things to consider with Bactrim. Advantages, I think, are that it's oral and we can do it twice daily versus if we were to use clindamycin or some beta-lactam agents, we would be dosing it 3 to 4 times daily, which can be difficult sometimes, especially when we're putting patients on longer durations of therapy. It's pretty cheap most of the time, and it could be a good alternative in patients that have beta-lactam allergies. But some adverse effects to consider and sometimes scare us a little bit are some electrolyte disturbances like hyperkalemia and hyponatremia. It can cause an increase in serum creatinine, but this doesn't necessarily mean that there's a decrease in GFR. And then sometimes it can cause blood dysprasias. This doesn't happen in all of our patients, and whenever we're treating more mild skin infections, typically we can get away with a shorter duration. So we wouldn't really be that worried about these side effects. But if we were to maybe consult COPAT on these patients and we were treating them for a longer duration, hopefully we would be able to monitor their labs and monitor for any adverse effects and the need to change to an alternative therapy if any of these arise. You can go to the next slide. So in summary, I personally think that Bactrim could be used for group A strep and Staph aureus skin and soft tissue infections if we need it, or it can be used as a good option for patients that go on oral therapy for longer periods of time, especially if we're able to monitor their labs. and monitor them for any other adverse events that are going on. That was all I had for the day. I'll open it up to anyone that has any comments or additional thoughts on Bactrim for skin and soft tissue infections or in general.